going to take you through the journey, and I'm going to show you the some of the part of the document. Our aim was very simple. We want to make it as simple as possible. We want to make it very easy readable and has a clear diagrams and algorithms that people can adopt based on evidence. And we want to have a consensus, clear consensus of the experts that were included in this panel. So first slide. This is the group that I was pleased to have with me. Of course, you can see we have a very experienced group of people who actually had a huge experience on cardiac intervention and in the region, and understanding the patients and the need of the community, which is very important. We have the international expert with us, Dr. Felix Mahfoud, as being our co-moderators, where he reviewed with us the literature, and we enlightened the discussion with him with his always feedback and opinion. Why the consensus? It's very clear. Hypertension is a significant global concern. It is a major risk factor for cardiovascular disease. There is a limitation of the pharmacological therapy. As we say, about only less than 30% of our population are actually reaching target. So we're really way behind in treating hypertension. And writing up the new consensus on something like a new modality, a non-pharmacological therapy for hypertension, we feel that will add a great tool to help our patients on the future. The consensus panel, as you've seen, there are a panel of experts in the Gulf region, and the way we did it, as our president explained clearly, we gathered as a panel, and then we divided the topic into sections, and we divided it between groups of experts. And after that, we gathered again and reviewed what each group has written. We actually went into editing and changing, and then after that we reviewed again, and after that we went into a process of voting. It's independent voting. Nobody knows what each one voted for. So, and the final draft was reviewed and voted upon, given to the medical writer, and then finally we have the final draft approved. We elected to make it simple, and we decided to make a grading system because we really want the reader to understand how strongly we feel on each statement that we're going to say. So we created the strong recommendation, moderate recommendation, and weak recommendation. Weak recommendation does not mean you should not do it. You may be considered in selected cases or specific circumstances. Moderate can be implemented based on clinical judgment and patient context. And of course, the strong should be implemented, and that's the way we felt, should be implemented on most cases. So we have the strong, moderate, and weak recommendation. We started, I'm going to take you through with an introduction about the size of the problem and how hypertension is actually one of the leading cause of stroke, cardiovascular complication, peripheral vascular disease, renal failure, and how this is actually costing the community and the healthcare a huge burden, and what's the prevalence of the resistant hypertension. And that's all been mentioned in our document with references provided. We talked about the challenge of resistant hypertension and what does that mean for resistant hypertension. And we agreed that this is a burden that needs to be handled. Then we talked about the new novel approach, which is the renal denervation. And we released the first statement. We voted all as 100% level of agreement that renal denervation specifically target the renal sympathetic nerve, which play a crucial role in blood pressure regulation, by ablating and modulating these nerves. RDN aimed to diminish the excessive sympathetic activity, thereby reducing blood pressure and potentially improving cardiovascular outcome. Each word is very well selected. Each word is reviewed, and then we did voting, and you had 100% voting on this statement. This is the mechanism of how RDN. So we agreed all that RDN works through the above mentioned mechanism. We discussed what are the evolving RDN technology, what is the FDA approved. We talked about the simplicity and the Paradise Recore system, and these are the two approved systems. We discussed other system which is not really approved, like the microwave or the cryoablation, which is still in research. And then we start going into the clinical evidence review, and we started by the unmet chapter. Dr. Nabil, who's there, he actually did a great job on the unmet section. And then after that, we reviewed the literature, and we in this particular chapter, we really emphasize the gap that we have on the Gulf region of treating hypertensive patients and the failure of the pharmacological therapy of reaching the target. And in that section clearly stated, and I was happy to hear yesterday that we have a GIS Hypertension Academy now, that the Gulf Interventional Society can play a pivotal role in advancing RDN in the region by promoting cooperative research initiatives, facilitating data sharing and analysis, developing and disseminating evidence-based clinical practice guidelines, and educating healthcare professionals on the appropriate use of the RDN. So we really need that umbrella who actually support this, because we need to move forward into a more organized working to help and support our hypertension caregivers to provide a much better care and hopefully reduce the cardiovascular risk. We did the analysis of the studies, and we actually looked at all the outcomes. We summarized it on tables, and we came with the first statement for the unmet. In patient already treated with multiple antihypertensive drug, RDN provide a durable device-based approach to blood pressure reduction. Strong recommendation, 100% voting from the group of the experts. So we all agree that it is a doable, it is a therapy that effective on patient with multiple hypertensive drug, and they are not reaching targets. Then we went talk about the naive, which is the off-med group. We summarized the literature. We looked at all the available literature with the two systems, the Spiral and the Paradise program, and we came with the third statement. RDN can be used for patients with mild hypertension, stage 1 hypertension, not started on medication. This is a weak recommendation. This is something you can do, but it's not strongly recommended, okay? So patient preference, all the other factors, patient intolerance to medication sometimes can be a factor, but this is voted as a weak recommendation. We talked about what's the referral criteria and how we do patient selections, and that's been summarized on the table. And we came to our fourth statement, the selection criteria. So what we're saying that selection for patients, you need uncontrolled resistant hypertension treated with more than or equal 3 medications, including diuretics, blood pressure reading in the office more than or equal 140/90, and confirmed with 24-hour ambulatory blood pressure monitoring. We modified the statement to be applicable to people who does not have the 24 hours blood pressure monitor in their clinic. So we asked them to do a 7 days home reading to average more than 135/85 from the 7 days home reading, which is also recommended by the AHA. We put a cut point of a GFR of more than or equal 40 mil, and that came as a strong recommendation. So if you have a patient, this is the criteria for the renal denervation as a definition of resistant hypertension. The other criteria: patient intolerance to medical therapy, patient with stage 1 hypertension and prefer to be off medications, patient with secondary hypertension and difficult to treat. So failed therapy for secondary hypertension, patient still hypertensive, you may consider this as an alternative or an option to reduce his cardiovascular risk. And this is weak agreement. The agreement here is 77-78%. We define what's medication failure and what does it mean before you actually move in considering RDN. We define what are the things you need to do when you do the home monitoring, and what are the lifestyle and the reversible causes. And we came of a definition of resistant hypertension that we say we recommend and encourage ambulatory blood pressure reading or 7 days home blood reading before confirming resistant hypertension. Of course, home reading, there is also a criteria that the patient had to sit for 10 minutes, and that is from the same arm, and after meal 2 hours. Based on multiple office visits or inpatient blood pressure reading to eliminate the white coat hypertension, elevate blood pressure due to stress. This was a strong recommendation that how we define resistant hypertension. We continue on going through the details of how to filter and choose patient, and we created an algorithm which is simple, and this is going to be a hard copy. Once we have this, we want to distribute this to all clinics. Hopefully it will be in everybody clinic that it will be given, and maybe in the very future with the GIS application we can have it also available. But it's very simple. You start from the top, uncontrolled hypertension. You do the confirmatory testing by either home readings or the 24 hours blood pressure reading. If it is high, you want to rule out this is not pseudo hypertension. You want to do the medication count. You want to actually make sure this is not white coat hypertension, and you want to make sure that this is not only brachial or artery sclerosis. And then once you've done that, you're going to actually move to ruling out secondary hypertension. If there's no secondary hypertension, you move to renal denervation. We actually defined as well what are the tests that you need to do to rule out secondary hypertension. We mentioned all the guidelines, considering that's an important part of any consensus, and what's the recommendation that went. And finally, we came up with our consensus, which is basically based on the current evidence. This is the statement at the beginning. Based on the current evidence, RDN therapy with radiofrequency ablation or ultrasound ablation is safe and feasible therapy for treatment of resistant hypertension. We recommend and encourage ambulatory blood pressure monitoring reading or 7 days home blood pressure reading before confirming and controlled resistant hypertension based on multiple office visit or inpatient blood pressure reading to eliminate white coat hypertension or elevate blood pressure due to stress. Detailed medication history to make sure that there is the medication failure, not adherence, to the problem. If the patient on at least 3 medication, including diuretics or a maximum tolerated dose, and has an ABM more than 130/80 or a home blood pressure 135/85 after confirmed medication adherence, then it will be essential to refer to an RDN clinic. The consensus panel hope that this recommendation presented can offer optimal treatment of hypertension on the Gulf Society and raise the importance of indication of renal denervation therapy in resistant hypertension patient. Tomorrow I'm giving at the same time a talk of how to set up an RDN program in your hospital, and I will encourage you also to attend because it's important to go through the practical step of the requirement to set up your RDN program. Thank you very much.